Okay, good morning, and I'd like to thank the organizers. Thank you very much for chairing this session. I don't have any really interesting, cool vignettes about the, gold bond powder to start with, but I do want to tell you, I hope that you all can really learn and appreciate something from this presentation, because we are, after 50 years, really entering a golden age of immunology. And I think, just watching TV every day, you're starting to see commercials, more and more commercials. People are calling you, asking you, about what is this immunotherapy and what's happening because of this incredible explosion. And I think a lot of that actually has come about because of some really dramatic successes that has occurred in the hematologic diseases, in CLL, and with newer types of therapies that are coming on the horizon. So I know when I first started coming to MDS meetings, for the most part, people said, why are you even coming? This is an immunology, why are you even here? And I feel like I'm a little bit vindicated at this point, because we're having 2 back-to-back talks on the microenvironment and the role of immunology, for sure, in this disease. So with that, I'm going to go forward. So today I really want to talk about 2 things. First, to discuss some basics with you on immune dysregulation, as well as just normal immune function, and also to give you some information about some immunologically based therapies that are progressing in MDS. And of course, these are all going to be not approved therapies at this point. So just basically looking at the immune system, we know that there's 2 basic types of immunity present. One is innate immunity, the other one is adaptive immunity. I don't really have to go through this with you, but basically I just want to highlight that in the case of MDS, we're really looking at largely a role for innate immunity, which is basically non-specific defense. It has a generic recognition pattern. There's no memory that is associated with it. And it's evolutionarily older system, and we see these type of genes are very overlapping even in plants. So with that, I really want to focus on this, and then basically a generic understanding. So we know from many studies going back for many years that there are multiple cytokines that are increased in MDS. We know that that's true in MPNs as well. So myeloid diseases, there's a lot of inflammatory cytokines. That you can see here is the list. We now know also that there are other inflammatory mediators. This is new, more evolving information, things like nitric oxide, arginase, and the danger-associated molecular patterns, which I'm going to talk to you more about. So we've known this for a long time, but we didn't really know exactly what was driving this, and there was no information about what was the real relationship between the disease pathogenesis and these inflammatory state. So first of all, let me just review what are the innate receptors actually composed of. First, functional activation of innate immunity occurs through the pattern recognition receptors, or the PPRs. So these receptors have broad specificity. They recognize related molecular structures, and they are designed by nature to react to pathogens. However, in the case where there is damaged or dying cells, there can be also cross-reactivity to normal or to the host tissues. So the first one, called the pattern-associated molecular pattern, or PAMPs, this is characterized by LPS, or bacterial products, as I mentioned. And then if it's a host tissue or a host molecule, then it's called a DAMP, or danger-associated molecular pattern. And this can be ATP, uric acid, as we know from people with gout, for actually bind to this type of receptor, DNA, RNA, double-stranded DNA and RNA in terms of pathogen-associated molecules. Things like HMGB1, which is a chromatin-associated protein, or something that I'm going to also talk about in a few minutes, and that's the S100 proteins. So one of the examples of these type of receptors are the toll-like receptors. And again, these are ancient types of receptors. They were actually discovered recently after I was in graduate school. So in graduate school, I was trying to identify something that bound to LPS. I pulled down a gel that was radio labeled with iodine. I probably had a toll-like receptor in my blot, and I didn't, sequence that. So I was kind of discouraged by that history. But anyway, this is composed of a family of 10 different types of receptors. These receptors usually dimerize through either homodimeric or heterodimeric interactions. The basic types of cells that normally express these are macrophages and dendritic cells. They have two different types of cellular localizations. They can either be cellular, extracellular expression, or in the endosomal compartment. And different ones of these toll-like receptors bind, as you can see underneath the figure, each one bind to different types of pathogenic molecules. So when these receptors signal, they engage through an adapter protein, something like MyD88, and this signals and primarily activate NF-kappa B. So NF-kappa B, as you know, is a really major driver of the inflammatory response, so that results in a lot of cytokine production after engagement of this receptor. So in addition to the TLRs, there's also NLRs. So I'm going to talk about that, I think, in the next couple of slides. But the DAMPs also bind to TLR4. So again, this is the S100 proteins, which I'm going to talk about in a second. So now, inflammation and disease. It's been said that inflammation may be the root of all or most diseases. So actually, there's a connection to cardiovascular disease, to other types of diseases in addition to cancer. And however, can we ask the question, is this really causing the disease, or is it a result of these mutations in the microenvironment or in the tumor cells that we just heard about? So I think that this is a question also that was just asked by the audience. So I think one of the things that we can see from the mouse, from the mouse models is that I agree with the previous speaker that we do need to have both a change in the microenvironment as well as a mutational event to drive this. But when we look at MDS, we are thinking about it in terms of a pathology, and that is the dysplastic features. So the dysplastic features, I believe, are really what is driven by this inflammatory milieu. So how is this actually connected to normal physiology? So basically, we know that in the case where myelopoiesis is occurring, that there is such a thing as stress myelopoiesis. So if there's an infection, there is an ultimate need for additional innate immune cells to be able to eradicate this infection. So we know that based on this nice work back in 2006, this is in a review by Hull, that there are a lot of toll-like receptors expressed on the stem cell as well as on the progenitor cells that skew myelopoiesis and away from a common lymphoid progenitor. And this is basically the rationale behind this system. So when we look at transgenic mice that overexpress this S100A9 protein that binds as a danger-associated molecular pattern to TLR4, it also cross-reacts and binds to CD33. So when it binds to CD33, we get amplification of that myelopoiesis. So in what you can see in this slide is that it also stimulates a type of cell called an MDSC, or a myeloid-derived suppressor cell, and these cells are very, very activated and also producing a lot of inflammatory cytokines and mediators. So in the MDS, as well as in this transgenic mouse model, you see expansion of MDSCs and expansion of these of these type of cells. So actually in these mice over time, what you can see is that just having this constant inflammatory microenvironment for a long period of time, it can lead to a dysplastic phenotype very similar to MDS without really truly having any genetic abnormalities. And actually, looking at patients, their MDS population don't have any of the genetic changes that we are normally seeing in the myeloid clone. So the second thing that we know is that another molecule just recently was published by Dr. List and his group, and this is the NLRP inflammasome in MDS. So this brings us to another key component of MDS. One is the expansion of myeloid cells, the dysplastic features, but also the presence of an apoptotic or a cell death, advanced cell death phenotype. So ineffective hematopoiesis, accelerated attrition, and inflammatory microenvironment actually is more consistent with having an NLRP3 mediated cell death. And this was this very nice paper that they just published showing that you have the recruitment of and activation of NLRP3 complexes by this adapter protein ASC. You have ASC polymerization and activation of a pro-caspase-1 mediated pyroptosis associated cell death. So this was really nice. I think it gives a new meaning to the inflammatory process and also brings forth some new types of therapeutic molecules. So then thinking about this as an ongoing process, how did MDS actually emerge? So one of the questions was addressed by Dr. Kamraji in a paper that we did with some collaborators at King's College. So we looked at patients who had coexisting autoimmune diseases prior to the development of MDS, and we saw that there were a number of different autoimmune diseases with actually those patients having a better overall survival. So when you had your response question, so the other study that was recently done, so you could always think that maybe this was a result of therapy. So we saw that hypothyroidism was the most frequently occurring, so that wouldn't really fit the case. And then in the study that was mentioned, looking at therapy-related MDS out of a study with 40,000 individuals, they identified 86 cases, and only azathioprine was 7-fold increase in the association. So drug-induced MDS doesn't really seem to be the existence. So really it's maybe this association with an inflammatory milieu. So as we know, not only are the TLRs and NLRs expanded, we know that TNF and other inflammatory cytokines and signaling pathways that activate NF-kappa B are also present. So this was one of the early papers that I wrote a long time ago, just thinking about how this could be impacting the evolution of the disease. So first of all, thinking about a lot of these inflammatory mediators, we see them in lower risk. And then as this clone propagates, then it would have autonomous functionality. And that would be more evident, so like what we just heard about with P53 mutations. So I think that this model actually still holds true, and we are really gaining a better understanding of how this all works. And we've already seen this particular slide. This was from Dr. Sheng Wei's paper in our group suggesting that there is an interaction of both the microenvironment, inflammation, and then the occurrence of mutations that might lead to the evolution of the disease. So now thinking more about how can we appropriately target this type of therapy, we know that the goal of most of this inflammatory process leads to the reduction in the effector arm or the adaptive immunity. And so this is a really hot topic, and one of the things that we know from this is that treatment with anti-PD-1 or anti-PD-L1 is able to reverse some of the immune suppression. And so in general, we know that in the immune status in MDS, there's more immune suppression and a less immune reactivity. So reversing that could be effective. And so with that, I'll just go through a couple of quick slides showing about new studies that are on the horizon for immune potentiation. And we can think about this in two ways. We can either suppress the innate immune responses, which so far I don't think has been too successful, but suppressing cytokines, causing differentiation of the MDSCs or other myeloid cells at the point when the patients are really exhibiting the MDS disease phenotype. It may be somewhat too late. I'm not sure about that yet, but I think we also need to reactivate the effector arm of the immune response to really see some type of clinical benefit. So potentiation of effector cells, either removing T regulatory cells or other suppressive populations, and breaking immune tolerance with these checkpoint blockade or other signaling mechanisms that expand T-cell therapy. And as what we've learned now from other cancers like melanoma, we know that multiple therapies added in combination are much more effective than just single agents. So then this brings me just to, we do have history with using immunotherapy type of drugs in MDS. So this is just 4 of the earlier trials that were conducted using ATG and cyclosporin or ATG alone. We know that basically, if we really think about this in the context of what we know now, we can think that actually this is just perhaps eliminating some of the inactive T-cell population, and it is allowing for reactivation. This is some of the results of the early studies showing that this is an effective therapy. And then this is just one of the slides from a patient that we had on a trial at Moffitt with Dr. Kamraji, and you can see that it can really lead to a dramatic improvement in hematologic responses. So now this is the next thing I want to talk about, and that's checkpoint blockade. So we know that anti-PD-1, anti-PD-L1. I'm not going to go through each one of these, and you have them on your presentation, but there's a number of trials that are open and enrolling. The last thing I'm just going to mention is that we know that we use lenalidomide. It binds to the molecule cereblon. This also has anti-inflammatory properties as well as immune activating potential. So it's actually within the realm of the immune modulatory drugs. And so here is just the overall schematic of how the IMiDs work. And what we see is we know that it has it gains the substrate degradation capacity to eliminate some proteins through the proteasome. As you can see here, this is expression of Ikaros, and that has been linked to an increase in T-cell function. And we also know that from these early studies that there is also an immune aggregate that's often evident in the patients on Revlimid. So just in conclusion, I want to just make note that there is evidence that there is inflammation in MDS, and I think that targeting this in the future with immunotherapy will be a very valid new type of therapy. And just in one last second, I want to make a note for people who may not be aware of our new National Myelodysplastic Natural History Study. This is an NIH, NHLBI and NCI funded clinical trial that's enrolling. We're up to around 200 cases. I'm the PI for the Central Laboratory and Biorepository. So hopefully there will be someone here that may be interested in joining this study. The idea is to evaluate patients longitudinally and to provide resources for the research community. So thank you very much with that, and I'll take questions.